I'd like to start by thanking Dr. Ridge and the organizing committee for inviting me to talk here. It's an excellent program, and it's a privilege to be here. So I'm looking at the timer. 27 are you giving me? Okay. So you'll have to pull me off because this talk is designed for 30 minutes as was instructed before, but pull me off when I'm done, when the timer goes off. So I have no conflicts of interest and no financial disclosures to make. The talk is titled Surgical Management of Oral Cavity Cancer, but I'm not going to show you surgical technique, no surgical videos or no fancy pictures. Instead, what we'll do is very quickly talk about workup and treatment principles. I'll use some oncologic outcomes data to set the stage for addressing two important clinical issues that I feel that surgeons can influence in terms of modifying outcomes in consultation with our other colleagues in radiation and medical oncology. And those are margins of surgical resection, and how to deal with them, and how to manage the neck. So in terms of workup, the oral cavity is perfectly accessible, very easy to examine. The surface extent of the tumor should set you off within the very first few seconds that you see the patient as to what course that patient's going to take and what the outcome's going to be, how your treatment's going to be planned. Exophatic tumors with well-defined borders have a less risk of incomplete resection, and consequently they have better outcomes. If you have a tumor with diffuse borders and it's infiltrating, that's a harder tumor to treat, and you can expect worse outcomes in those patients. You also want to look at how the tumor is related to certain structures within the oral cavity. The salivary duct openings is a good example, and how the tumor is related to bone. So the surface dimensions of the tumor are easy to examine in the oral cavity. It's a very accessible location. What's more difficult to assess is the depth of invasion of the primary tumor, and why is that important? We know from past experience that if a patient presents with a superficial tumor, 2 millimeters or less, that patient is at less risk for nodal metastasis, and they will have a very good outcome in terms of survival. As the tumor depth increases or the tumor thickness increases, the risk of nodal metastasis increases, and consequently survival drops, and so that for the thicker tumors that are more than 8 millimeters or a centimeter thick, the risk of nodal metastasis is almost 50%, and therefore survival drops. So that's something that's very, very important to factor into the treatment plan, and that's where radiology comes in. So radiographic imaging is essential to assess not only the deep extent, but also invasion of bone. It definitely is superior to palpation in detecting lymph node metastases. And you heard the talk on bone invasion and perineural spread before. But for oral cavity cancer, CT is really the workhorse, and you use MR for answering specific questions. I do not feel that PET scan adds much value in terms of treatment planning over a good quality cross-sectional anatomic imaging, but that's a point of debate. In terms of treatment, this is a surgical disease. Oral cavity cancer is managed primarily by surgery. If it's an early stage cancer, surgery alone is enough. If it's more advanced, surgery is followed by either radiation therapy or a combination of radiation and chemotherapy. And the indications generally depend on certain features of the primary tumor, advanced T stage, margins, and other histologic features. Features of the neck, more than 2 lymph nodes, more than 1 level involved. External extension is a big issue, and whether you're able to get complete resection in the neck or not. When you add chemoradiation, it's for 2 generally well-recognized indications, positive surgical margins and extranodal extension. The 2 indications for adding chemoradiation generally after surgical resection. But it's important to understand that you want to choose adjuvant treatment very, very carefully, especially for the oral cavity, because the consequences, the side effects of treatment can be pretty drastic when you chemoradiate patients with oral cavity cancer after surgery. So that's where multidisciplinary consultation and a large measure of common sense often is needed. Now, I'll share with you some data that's yet unpublished. About 1,800 patients treated between 85 and 2012 at Memorial Hospital. Majority of them were either tongue or floor-mouth cancers. The majority were early stage 1 or stage 2 tumors, but it's of interest that about a third of patients present at stage 4 in the oral cavity. That's a pretty significant number, even in New York City. So that kind of influences the cancer-related outcomes and control rates. As you would expect, about a third of patients received adjuvant post-op radiation, and a small percentage got chemoradiation because of additional risk factors. Overall, about a third of patients will fail either locally or in the neck at 5 years. And most of these patients, most of these recurrences occur within the first year, and by the second year, the recurrence rates have plateaued off. So that kind of factors into how frequently you follow these patients after treatment. Survival rates are pretty good, 75% 5-year disease-specific survival. In these patients, overall survival is lower because there's some attrition from comorbidities and comorbid conditions. And about 2/3 of patients will experience some form of recurrence during their lifetime at 5 years. As you would expect, early stage tumors do better. Stage 1 and stage 2 do better than stage 4 tumors. And this is largely driven by the impact that nodal metastasis has on survival. So that if you have positive nodes in the neck, the survival drops by almost 50% if you have N2 and N3 disease in the neck compared to N0. So against this backdrop, what I'm going to do is spend the rest of the time that I have, 21 minutes, on margins of surgical resection and management of the neck. And I'll try and accomplish both goals if I can. Now, it's no secret, if you have a positive margin, you don't do well. So patients with positive surgical margins have significantly worse outcomes. No surprise there. It's also no surprise that if you have a larger tumor, the risk of getting a positive margin is higher. So from T1 tumors to T4, the risk of getting a positive margin climbs up. The thicker the tumor, the more the risk of a positive margin. So these are all expected findings. So what we are doing in clinical practice effectively is we use the margin status as a surrogate for predicting the biologic behavior of the tumor that you're treating. In other words, if you have a positive margin, that's taken to denote an aggressive tumor, and you escalate treatment by adding chemoradiation or radiation to the mix after surgery. But it's not that straightforward in my judgment, because here you have two situations. You have a tumor that's been resected with a clinically wide margin, and you have that same exact tumor that's been resected with a narrower margin. A positive margin in these two situations cannot be the same if you take the extent of resection into account. So in other words, if you have a tumor that's resected with a large cuff of normal tissue and a positive margin, that's not likely to be the same as an inadequately resected tumor and a positive margin. But that's not really how we make decisions in real life. You look at the pathology report, there's a positive margin, that patient goes for chemoradiation, or at least the discussion starts. So what we did was we hypothesized that the ratio of the volume of the tumor to normal tissue within a surgically resected specimen can be used as a measure of adequacy of resection. It's a primitive, crude kind of assumption, but this was just to prove the point that looking at the pathology report and deciding on adjuvant treatment should be a practice that needs change. So this is over 600 specimens of T1 and T2 early stage tongue cancers that were looked at retrospectively. And when you look at the volume of tumor within the specimen, the tumor specimen index is what we called it. The average was 41, the number. In other words, 41% of the specimen was occupied by the tumor in one single average dimension. And the outcomes of interest were locoregional recurrence and disease-specific survival. And we ran time-dependent ROC analyses on these two outcomes. And the optimal cutoff at which changes were noticed in both these outcomes was 45. Not unexpectedly, if you had a higher tumor specimen index, that is less normal tissue and more tumor in your specimen, it predicted closed or positive margins. That's understandable. But we were surprised to see that if you account for the adequacy of resection and factor that into a multivariate analysis for locoregional recurrence and disease-specific survival, suddenly the independent influence of margin status falls off, which gives you pause and supports the hypothesis that adequacy of surgical resection is an important factor in interpreting the prognostic significance of surgical margins. So you don't automatically want to act on a pathologic report that mentions a positive or closed margin. If possible, in many of these patients, you may want to consider an additional resection to achieve a wider resection if possible. Particularly in the tongue, the issue of margins and assessment is very difficult, and it's inaccurate if we look at current technology. And the reason, the underlying reason is that once the tumor infiltrates into the muscle of the tongue, there really is no barrier to tumor spread within the tongue. And there's no real clinical or intraoperative tool that you can use to evaluate the extent of tumor. We use frozen section, we use histopathology, but these are all kind of crude and inaccurate methods to assess margins. There's also the issue of shrinkage of the specimen. So from the time the surgeon draws a line around the tumor to the time the pathologist actually assesses the margins, the distance between the edge of the tumor and the normal tissue has changed. So there are several limitations in how things are interpreted in real life nowadays, but yet we treat all of those patients based on a positive margin with more aggressive treatment. So the question that we're trying to answer is, can you really image cancer cells or margins in real time inside the patient? And if you look around, there's a host of optical technologies that are around. What we've worked on for the past 8 years or so at Memorial is a technology called in vivo reflectance confocal microscopy. What it really is a laser that shines across the surface of tissue. It's like doing a photocopy of the tissue surface. It reflects, the light reflects off the surface. It's collected by a optical mechanism and is analyzed by a computer. So this is a clinical trial that we've just started 8 years of development later. This is a patient with a biopsy of a small lesion on the lateral border of the tongue. Hard to tell where the cancer is and where scar tissue is. Based on palpation, this is the sort of tumor delineation that the dotted lines represent the induration around the site of the biopsy. And a centimeter or a centimeter and a half of normal tissue around what you think is tumor is taken as a margin. Now, this is the way we practice surgery right now. What we're doing is using a handheld device. It's like a hair dryer with a pointed end, and you have the laser shine through here, and it collects information from the surface of the tissue that it's scanning. So you can actually see cells with nuclei as you scan across the surface, and you're able to collect real-time imaging data to see if it looks like cancer or not, and try and define your margins. As you go deeper into tissue, you can actually see the papillae and the fibrovascular cores. Actually, I don't know if it projects well, but these are capillaries with red blood cells flowing through them. So using this kind of technology, you can actually map out normal versus precancer versus cancer pretty reliably. And now with digital staining techniques, those black and white images, which were not very pretty to look at, you can actually replicate H&E stained pathology very, very quickly within less than a minute or so, real time in the operating room. So this is where we're headed to in terms of margin assessment and intraoperative imaging. So 12 minutes and 37 seconds to manage the neck. If you have a clinically positive neck in a patient with oral cancer, that's a pretty straightforward situation. You do a comprehensive neck dissection, dissecting all levels. Generally, you spare the tissue that's above the spinal accessory nerve. Data came out from Memorial. Dennis Krause was the author on that. And that's a safe operation to do. And then you add post-op adjuvant treatment as indicated. The clinically negative neck is defined as a neck where there are no clinically palpable nodes and there's no radiographically abnormal nodes. And that's a little difficult to define because of heterogeneity in interpretation. There is no real technology right now that can image microscopic cancer in vivo in the neck. And that kind of introduces limitations in definition of the CN0, the clinically negative neck, and hence there's some heterogeneity in stratification for treatment. Now, having said that, the therapeutic options you have right now is either observe the neck or you do a neck dissection, or an elective neck dissection as it's called, because there's no demonstrable metastatic disease at the time of surgery. For elective dissection of the neck, we know from data that came out of Dr. Shah's work at Memorial that the highest risk for lymph node metastases is in the top 3 levels, level 1, 2, and 3, for oral cancer. So that's what you target in a supraomohyoid or a selective neck dissection that takes out levels 1, 2, and 3 as an elective operation. And the rationale is that if you catch these occult or clinically occult nodal metastases at an early stage, you have a lower volume of disease and you have a higher chance of cure. And really, the morbidity of selective neck dissection or a supraomohyoid neck dissection is minimal. If you do it well, the scar's barely visible, and patients return to their normal activity pretty easily. Now, having said that, if you routinely dissect everyone's neck with oral cancer, you will overtreat the majority of patients because only about a third of patients have clinically occult mets. And there's also this thought that you may change lymphatic patterns and increase risk on the other side, which is not really of great worry to most people. But having said that, there's morbidity, cost involved. And most importantly, 4 randomized trials have demonstrated no survival advantage for elective neck dissection over observation until this recent randomized trial came about, published in August last year, looking at elective neck dissection versus observation and therapeutic or a neck dissection when the patient failed after a period of observation. This came out of Mumbai, India. About 600 patients collected over 10 years of study, basically looking at early stage T1, T2 clinically node negative patients with lateralized oral cancer. And they were prospectively randomized to either elective neck dissection or observation, and they were stratified by T stage and preoperative ultrasound findings. So they had built-in examination of the neck by ultrasound into the study. And the 2 aims were whether there's a survival advantage for elective neck dissection versus observation. And the other question they asked was, does ultrasound detect nodal mets early during surveillance? Now, that's a point of contention. I don't think that needed any study, but that's how the study was designed when it started 10 years ago. For the patients that were observed, there was a pretty rigorous follow-up schedule, as you can see here, and they were randomized into physical examination alone versus physical examination with ultrasound. Again, a study design that is pretty much irrelevant in my judgment in 2016. If you have an ultrasound machine, you should use it. Otherwise, it's of no value. So if you survey the neck with ultrasound, it's definitely going to be much more accurate than physical examination alone. So in some regards, that study design is not really relevant to practice in the United States. For elective neck dissection, they planned to dissect levels 1 to 3, as I just pointed out, a supraomohyoid neck dissection. And their study design was that if they found metastatic disease intraoperatively, then they would dissect level 4 and 5, do a comprehensive neck dissection. Of note, 1 in 5 patients ended up getting a comprehensive neck dissection based on intraoperative findings, which brings you to that question of how reliable is your ultrasound preoperatively if 1 in 5 patients needed a neck dissection based on intraoperative findings. Also, there was a difference in how these patients were treated postoperatively. Patients who got elective neck dissection, almost 50% of them had postoperative radiation therapy, and the majority were to both the primary and the neck. In contrast, if the patient was observed, the neck was observed, only 34% had radiation therapy, and the majority were treated only to the primary. And that kind of translates into these survival differences. So not surprisingly, if you look at elective neck dissection, those patients did better compared to the observed group, where they waited for the patient to fail in the neck and then treated them with elective neck dissection and adjuvant treatment as indicated. So dissecting this a little further, if you look at the observed group, almost 50%, 45% of patients failed in the neck. They did not report how long it took for the patient to fail. So we don't know how quickly these recurrences occurred. More importantly, they did not report how the recurrence was detected, whether it was an ultrasound or physical examination or both. And that's also important because about 18% of patients failed at stage N3. That's a node that's 6 centimeters or more. Now, that's a problem with your surveillance policy if you're seeing patients at frequent intervals, 4 weeks, every 4 weeks for the first year, every 6 weeks for the second year, and so forth. And that number tells me there's something not quite congruent with how we practice medicine here in the US. Also, about 30% had a node that was larger than 3 cm. That's an easily palpable node in the neck. Most of these patients had extranodal spread at diagnosis of recurrence. And about 20% were in fact unresectable. And that's a huge problem with surveillance. So that's something that you don't want to see if you decide to observe a patient's neck. This is a recipe for disaster. That patient is unsalvageable if you put him down the path of observation without thinking. So what we do is, at Memorial and in most other places in the US, we pursue a policy of selective or a selective policy of management. We select patients for observation or elective neck dissection based on certain criteria. Where is the tumor located? What is the size of the primary tumor? What is its morphology? Is it exophytic? Is it endophytic? And most importantly, the depth of invasion of the tumor. And we use all of these risk factors to decide on whether the patient should go into observation or elective dissection of the neck. And I'll share with you some data. Again, over 1,300 patients with a clinically negative neck treated for squamous cell carcinoma of the oral cavity. It's the usual patient population, smokers, drinkers, and about 2/3 of patients got an elective neck dissection based on the criteria that I just outlined for you. About 40% got observation of the neck. And as you would expect, most of these patients had cancers of the oral tongue and floor of mouth. Most of these were early stage cancers because they presented with a clinically negative neck, T1 and T2 primary tumors. And about 1/3 had occult nodal metastasis. So a clinically negative neck but there was a metastatic deposit or deposits found in their lymph nodes on neck dissection specimens. And most of these were in levels 1, 2, and 3. Not surprisingly, if you look across the literature, about 30 to 40% of these patients with clinically occult, microscopic, or subclinical metastases in the neck from oral cancer will have extranodal extension. So about 43% of our patients had extranodal extension in the electively dissected neck. And if there was pathologic disease in the neck, most of these patients ended up getting postoperative radiation or postoperative chemoradiation. So if you look at the results of these, of this kind of selective policy of managing the neck, the patients who had elective neck dissection, the 5-year survival rates are very comparable to those who had observation. So 5-year disease-specific survival rates are pretty comparable. The so-called true node-negative patients, patients who had a pathologically negative neck after elective neck dissection, and those patients who never failed in their neck after observation obviously did much better because they never had metastatic disease in their neck. So that kind of bears out the selection policy. On the other hand, if the patient had a positive node in their elective neck dissection, or God forbid they fail in the neck after observation, those patients are going to do worse, the so-called true node positive patients. And the emphasis here is that if you look at the patient with a clinically negative neck, most of these patients do not have microscopic disease in their neck. So what you're really trying to do is catch these patients who have disease in their neck, which is identified either through failure in the neck after a period of observation or on histopathologic examination after elective neck dissection. And if you can somehow identify these patients ahead of time, you can better triage them for treatment. And sentinel lymph node biopsy is reasonably and getting increasingly popular in Europe, not so much in the US, as an intermediate kind of way of detecting lymph node metastases in the neck. I won't belabor the advantages and disadvantages, but it's not caught on in the US. What we're doing here at Memorial is we're using nanoparticles. Admittedly, this is for melanoma, but it's the same principle that can be translated to oral cancer. And what these are, they're hollow silica shells, about 6 to 10 nanometers in diameter. They encapsulate a fluorescent dye, and on the surface, you can put on radioactivity and peptides that are selective for the tumor model that you're trying to study. This is a mini swine model of melanoma. This is a regular FDG PET scan, and you see a lot of nonspecific activity in reactive lymph nodes. Is that time or not?
Can you sum up a little bit?
1 second. So basically, you inject, so this is FDG PET, that's nonspecific. If you inject these C dots around the tumor, you can very specifically detect melanoma metastasis. And this work has led to a phase 1 clinical trial in patients with melanoma where you can inject the fluorescent dye, look through tissue, and identify fluorescent sentinel nodes intraoperatively. So in terms of challenges, you're looking for in vivo delineation for both margins and metastases. But I hope I've showed you that if you're looking to get optimal treatment outcomes for your patients, you have to look at multidimensional host and tumor characteristics, appreciate the biology of the tumor, and use a lot of good clinical judgment and common sense. And that's the last slide. Thank you.
Great job.
All right. Thank you.
So